Hello, this is Anil here at DiCarmel International Trainers, the expert NCLEX trainer. So today let us learn some new interesting facts regarding NCLEX preparation as well as the methods to properly analyze and answer the NCLEX questions. And the topic I have chosen today is Hyperemesis gravidarum. And most of you would know what it is. And let us get started with a question review and we'll go into the topics. So let us go through this question together. Which of the statement by a student nurse regarding the care of a patient with hyperemesis gravidarum would be correct? And the options we have: first, I should expect rising blood pressure with hyperemesis. Option 2, +1 or +2 proteinuria is an expected finding with hyperemesis. Option 3, I should make sure to collect the patient's urine for ketones. And option 4, hyperemesis management always include hospitalization and IV fluids. Okay, and I believe everyone know what hyperemesis gravidarum is. I'm just going to show you a quick image on the next screen right here. Okay, so what is hyperemesis gravidarum? Okay, so it is excess nausea vomiting of early pregnancy which can lead to dehydration, electrolyte, acid-base imbalance. And also you might know it's a possible reaction to the rising level of HCG, right? Everyone know what is HCG? That's a human chorionic gonadotrophin. That's the hormone which is produced from the chorionic villi, which is the site of the implantation of the fertilized ovum. Yes, at the point where the ovum gets implanted, there is formation of blood vessels that will connect the implant and the endometrium. And from that side, there will be formation of chorionic villi, which will produce HCG. And that's what causing the symptoms of hyperemesis. So as you can see, it's a possible overreaction to HCG which peaks around 6 weeks and decline by 12 weeks. So keeping this information in mind, let's go back to our question once more. Which of this statement by a student nurse regarding a patient with hyperemesis is right? So let's see the options once more. The first one, I should expect rising blood pressure with hyperemesis. Option 2, +1 +2 proteinuria is expected. I should collect urine for ketones. And finally, hyperemesis always managed with the hospitalization and IV fluids. So let us see how, this is what I strongly recommend. Don't go straight into your preferred answer, rather try the elimination. We are talking here about hyperemesis, which is increased vomiting. So that's going to make the patient possibly dehydrated, right? Patient can have decrease in blood volume. If blood volume decrease, will that person have high blood pressure or low blood pressure? Likely low blood pressure, not high. Right? So high blood pressure we know which can happen probably from second trimester, what we call gestational hypertension, right? The PIH, everyone know what is PIH, which can lead into preeclampsia and then eclampsia. We'll talk about that later. So again, we are talking here regarding a patient with a continued vomiting, dehydration, less the chance the patient will go into high blood pressure. Rather, the blood pressure can go down. And then where do we see proteinuria? Do we expect proteinuria with hyperemesis? We talk about proteinuria again with the pregnancy-induced hypertension, right? We just heard preeclampsia and eclampsia. That's where we usually talk about proteinuria. So lesser chance, again, that is a possible answer here. And then what do we have the third one? I should make sure to collect the patient's urine for ketones. Okay, why should I collect ketones? I think we are used to hear ketones when we talk about diabetic ketoacidosis, isn't it? Or I'll come into that in a few minutes as well. Okay. So yeah, that's something we talked there. Do we expect that here? Maybe. We don't know yet. So let's leave that there. And the last option we have, hyperemesis management always include hospitalization and IV fluids. If you have done enough questions by this time, you would already know options that contain always, never, ever. So that kind of absolute terms automatically kind of make the option wrong. Not necessarily, but it's a good possibility. So let's leave that out there as well. Because practically you all are nurses who are possibly listening to this. So you know that not always the patient is in a hospital with hyperemesis. It's a condition that may subside by itself over a few days. Okay. But sometimes just for a couple of days they might need a hospitalization and similar interventions. Now let's go back to the options once more. Yes, so we heard the option 1 we already have eliminated because with the continuous vomiting and dehydration, blood pressure goes down, not goes high. So option 1 is out. And then option 2, proteinuria, we heard that is typically something that happens with the PIH. not with the hyperemesis. And option 4, we heard hyperemesis does not necessarily need hospitalization and IV fluids always. So that means option 1, 2, and 4 are out. So what are we left here? I should make sure to collect patients' urine for ketones. And so that is our answer. So let's go to the explanation. How come a patient with hyperemesis can have ketones in the urine? Okay. And what are ketones? And how does this patient will build up ketones? How will that come out through urine? So that's what we're going to talk briefly here. Okay. And to understand that, I'm going to show you some other diagrams here. So again, you all might be knowing, the 3 major sources of our nutrients. So we need energy, right, for us to function every single day. We need energy, and the 3 major sources of our energy are carbohydrate, fat, and protein. So as you can see in this diagram, yes. So the first one is carbohydrate in the list, and then it is fat, and then it's protein. So normally, the energy breakdown, the energy release starts from the carbohydrate. That's the easiest one to break down. And the energy which comes out of carbohydrate that supports and helps to break the fat as well. So then fat also releases energy. So that's how it continues. So again, it starts with the easiest one, carbohydrate, then it goes to fat, then it goes to protein. So what happens with the hyperemesis? If a patient has continuous vomiting, they're not really retaining anything. They're not able to eat, maybe for a couple of days. They're going to be depleted of their stored energy sources, primarily carbohydrate. So now there is no carbohydrate. Now body starts to break down fat by itself. In normal case, I told you, fat breakdown need the energy from carbohydrate. So without that, if fat breaks down by itself, what is going to happen? It can produce ketones as a waste product. And you might know ketones are acidic. So that can cause a patient to go into ketoacidosis. So that's where option 3 becomes relevant in this question. So again, the option 3 says, I should make sure to collect patients' urine for ketones. That means this patient can develop ketones and ketonuria. You may also have heard a patient with hyperemesis can have metabolic alkalosis as well. Now it is more confusing, isn't it? We were talking all this time about metabolic acidosis. Now we are switching into metabolic alkalosis. How come both can happen in the same patient? And let us try to understand that as well. If you are continuously vomiting, what happened? Our stomach has hydrochloric acid, right? In other words, stomach is acidic. The only part of our GI tract which is acidic is stomach. So if you are continuously vomiting that out, what is going to happen? We're going to be short of acid. That's where the patient can go to metabolic alkalosis. Whereas we were talking, if patient is not able to eat for a few days, they don't have no more carbohydrate left. So they're going to start to break down the fat by itself, and that can release ketones. Ketones are acidic. That can cause ketoacidosis, which can lead into metabolic acidosis. So I believe this information is getting complete here, and it gives a clear answer why a patient with hyperemesis can go into ketosis and why we should check the patient's urine for ketones. And also, let me bring up one other thing in this context. Now, we were talking earlier about diabetic ketoacidosis. So how are they relating? What happens with the DKA? What happens here? Let me try to explain that as well with the same diagrams we were going through. So what happens in diabetes? The same scenario, normally our primary source of energy is carbohydrate. And the energy from carbohydrate helps fat to break down, release energy, and then it helps protein as well. But in case of a diabetic patient, what is happening? We know they have too much of sugar. But where is that sugar? The sugar is in the blood. We want the sugar in the cells. So it is the cells which undergoes the metabolic process and releases the energy. So when there is no insulin, the sugar from the blood cannot get into the cells. So that's where, again, the patient is going to be deprived of carbohydrate. Even though there is a lot in the blood, it is not in the cells. Now the cells are again going to start to break down the fat by itself. And that can produce ketones as a waste product, resulting in diabetic ketoacidosis. So I believe now it's clear to everyone how hyperemesis can cause both metabolic alkalosis and metabolic acidosis, as well as we learned how to analyze, how to eliminate the wrong options and get into the right answer. So please do wait and watch for more videos from DiCarmel, and make sure you subscribe and you don't miss any of our important notifications. Thank you.